Hi, this is Dr. Purcell, and let's review just briefly 3 drugs from our psychotherapeutic drugs section that have to do with anxiety, mood, and depression. We're looking at chapter 16 in our Lilly textbook, and the 3 drugs I'm going to focus on here are all pretty close to each other in the book. I'm going to make this page look a little smaller so that you can see this whole list of drugs here. We have a nice big arsenal of drugs for these issues of anxiety, mood, and depression. We're going to look at bupropion on page 261, dualoxetine on 262, and fluoxetine on 262. Dualoxetine and fluoxetine are cousins. They're very similar to each other. But you can see it's a big chapter. There's a lot of reading, but we're really going to just hone in on these 3. They're used quite often. And if you understand these, you'll understand a lot about some of the drugs that are used in this area. Do understand a little bit about what it means, what affective disorders are. You're going to encounter this when you do psych mental health. You'll learn more about it. But remember, affective is about mood. So when we talk about mood drugs, we're talking about affective disorders. Anxiety is one of those, and here's a definition here for anxiety. Bipolar disorder is not an affective disorder. It has, it's not just about mood. It has mania and hypomania with manic depressive illness. It's very much an illness. Here's a depression. Here's a definition here for us with depression. And just remember, the clinical diagnosis of depression indicates that this is not something that a person is deciding for themselves. They're not just having a pity party. Depression is a real chemical imbalance in the brain and the body that causes this emotional state that's abnormal. And there's no shame in getting treatment for this. Here's mania again, and let's see another one in here that I might want you to look at. Psychosis. Psychosis, again, is not an affective disorder. It's a serious mental illness when people become out of touch with reality. Psychotherapeutics, this is the chapter in the section that we're on. And that is the treatment of emotional and mental disorders with therapy, and some of that's pharmacology. Psychotropic drugs are capable of affecting mental processes, and generally because of the drug. If it's a psychotropic drug, it's usually the medication that's doing it. There are psychotropic agents like LSD that causes the same thing. It causes a change in mental processes. And as we come down, it starts with an overview of mental illness and affective disorders. And usually most treatments are limited to some psychotherapy along with some short-term drug therapy. But long-term pharmacotherapy with psychotherapy is usually recommended when emotions or behaviors actually start to affect quality of life, the ability to carry out normal activities of daily living, affecting social functioning, occupational functioning, where they can't go to work. And this is something that's been happening over an extended period of time, at least several months. And let's just remember, the exact causes of mental disorders is not fully understood. I don't know if we'll fully understand it, but we do know that there are some functions within the brain, within the neurotransmitters, that are responsible for some of the affective disorders and the mental illness as well. We're going to come down on through and look at anxiety. It's an unpleasant state of mind characterized by a sense of dread and fear. And sometimes it can be brought on by things that have happened in the past. And so it's based in reality. Or sometimes it's based in something you haven't experienced before. And there's really, when it persists and it's disruptive to somebody's life, we start looking at these different distinct disorders. And so anxiety can be an obsessive compulsive disorder, post-traumatic stress disorder, A generalized anxiety disorder, GAD, which means we can't really put it into one of the other areas here. There can be panic disorder with or without agoraphobia, which is the fear of even being outside and around other people. Sometimes social anxiety disorder is one of these, social phobia, and then there are simple phobias. If somebody is hired to be a marketing or salesperson and their territory is quite vast and they're expected to travel long distances on a regular basis and they're afraid to fly, that's a simple phobia and it may really impact their ability to carry out their job. And so in this case, that might be something that could be treated with psychotropic medication. So anxiety is a normal reaction to stress, but believe it or not, there are studies that show there are about 5 to 8% of adults who suffer generalized anxiety disorder, and it goes on to explain more about that. And then here's about our affective disorders, and I'm not going to go really deep into all of this. You're going to get this later. I just want you to have a little bit of an understanding of where the medications come in. These are the mood disorders. They're characterized by changes in mood and can go everywhere from mania all the way down to depression. So from the very high to the very low in the emotional range. Some people have both, and that's the bipolar disorder. It used to be called, I can't even remember now what it was called, but now it's bipolar disorder. And then we have psychosis, which is really a severe break with reality. And people, yeah, here it is. The hallmark of psychosis is a loss of contact with reality, complete and total. Primarily, these are known as schizophrenia or a drug-induced psychoses. A lot of them come from the use of methamphetamine and the incredible paranoia caused by the use of those drugs. So psychotropic drugs are widely prescribed in the United States, and there is inherent variability in symptoms and diagnoses of mental disorders. And so one person's anxiety is not the same as another person's anxiety. And because of this, the effects of these drugs are less easily quantified than other types of medications. So the quantified meaning, I always tell you, how are you going to measure for therapeutic response? So when you give acetaminophen because someone has a fever, the therapeutic response is that their fever comes down. Or you give insulin because of the high blood glucose level, and their glucose levels come down. Well, it's harder to measure a therapeutic response in the use of psychotropic agents because of the variability of symptoms across people. So the way we measure effectiveness with these drugs is usually verbal reports from patients about how they're coping and their level of improvement and their functioning in society and in their workplace. Oftentimes, how we select the drugs can be a trial and error process. And it can be very frustrating, both for the prescribers and for the patients. But it really needs to be some patience and time to get the right drugs that we need to treat. Anxiolytic drugs are usually our benzodiazepines, and there's some other miscellaneous drugs. The one we are looking at, oh no, that's not our drug. This is a buspirone. Looks very similar to the other drug that we are using for this section. Our other drug is, now I can't think of it. Buspirone is this one, ours is bupropion that we're going to talk about. So really, we're not going to cover any of the anxiety drugs here, but I want you to just appreciate so that when you go to your psych mental health class, you'll see how many drugs can be used to help treat anxiety. So again, it might take a little while for somebody to find just the right drug for them to help them with their functioning, but at least there's several to choose from. You can see that the majority are PO, which makes sense when you think about the setting in which these are taken. So as we come down, let's find our drugs that we want to cover here. I apologize for all the scrolling. We are going to start looking at some of our mood stabilizing drugs. We should find our good friend in here. Our fluoxetine, there they are. Here's fluoxetine, and duloxetine should be under here. Here it is. Okay. So we have our fluoxetine and duloxetine. Let me go back up here to the top so that you can see what this box is. I just wanted to find our drugs in there. Here we go. So table 16-4. These are mood stabilizers and antidepressants. So these are the things that are going to help with people with their daily life being able to function in society, function in their families, and function in their jobs. And again, this is chemicals in the brain that we're talking about that have to be modified. Look on the right-hand side under route. They're almost all going to be PO. And they have to be, otherwise people would not be able to really do these on an everyday basis as outpatients. So we have a generation, the first generation of antidepressants that were used were called tricyclics. And they had some effect, but basically they dulled or manufactured a mood. So Elavil is in here. You may have heard of it before, amitriptyline. These are highly addictive drugs as well, and became misused. Instead of really helping depression, they became a problem. Then we had our tetracyclics here, which were first generation and second generation here. Remeron really had a lot of problems with that drug. And then we have the MAOIs. You'll learn more about those in psych mental health. And our second generation drugs is where we really started to see progress in psych mental health and in helping people with everyday depression, or clinical depression, not massive depressive disorder, which is going to require a combination of drugs and therapy intensely. But the everyday disruption in functioning due to chemical imbalances in the brain. And there's a nice variety under SSRIs, which are your selective serotonin reuptake inhibitors. Look at this. We have 1, 2, 3, 4, 5, 6, 7 drugs, and fluoxetine is our prototype drug here. That was pretty much the first one, or maybe the paroxetine, the Paxil that came out, and sertraline, Zoloft. Those were some of the first ones that came out. But if one doesn't work for someone, then we can try another one. Then you have your selective norepinephrine reuptake inhibitors, and here we have 4 that work really well, and duloxetine is our prototype drug here, also known as Cymbalta. And because they work on norepinephrine and they block the reuptake, it also has a secondary benefit with the SNRIs of helping with chronic pain, like the chronic pain of fibromyalgia, for instance. So just because someone might be on duloxetine or venlafaxine doesn't mean that they have depression. It could be that they're being treated for another disorder, that like fibromyalgia, that causes widespread neuropathic pain. So let's come down. We're gonna look at some drug profiles, and lithium is not one of our drugs. But here's some understanding about how antidepressants do work in major depressive disorders. And what they do overall is they increase the level of transmitter concentrations. So we need transmitters in our CNS to get the message across. So in order to get more nerve impulses, you have to have more neurotransmitters. And the fewer neurotransmitters you have, the fewer impulses you'll get. So the neurotransmitters directly involved with depression, we have been able to find out, are serotonin, dopamine, everybody likes a little extra dopamine, and norepinephrine. These sound a little familiar, dopamine, norepinephrine. Remember our catecholamines that help us when we're dying, and you can give these to people and it brings them back to life? Well, when you don't have enough dopamine and norepinephrine, you don't get enough nerve impulse, which is why you die. And that's why we give these, to get those synapses going and get the patient back to life. So here, these neurotransmitters are coming back into play again. So without a real true 100% understanding, treatment of depression with the drugs we are talking about here is based on the belief that it's alterations in the levels of these neurotransmitters that are responsible for causing depression. So the widely held hypothesis that helps to explain depression in these terms is the biogenic amine hypothesis. You will learn more about that in another class. But basically, this hypothesis says that depression results from a deficiency of neuronal and synaptic, wait for it, catecholamines, primarily norepinephrine. So let's look at that again. So you have depression results from a deficiency in these catecholamines. And mania happens because of an excess in these things in the brain. So here's a picture of how this is a graphic of how that hypothesis plays out. Then there's another hypothesis regarding the cause of depression, and that's the permissive hypothesis. And that led to the creation of selective serotonin reuptake inhibitor drugs, also known as SSRIs. And they have been a very, very good introduction or good part of treating depression. What the permissive theory says is it postulates that reduced concentrations of serotonin predispose patients that already have affective disorders. And so then the depression results from decreases in both serotonin and catecholamine levels. So we're just focusing on depression right now. But let's see, so then there's the mania. So then the permissive hypothesis is illustrated here. And then again, there's a dysregulation hypothesis. And they all essentially are starting to talk about the same thing, and that these nerves and their transmitters are what need to be the focus of pharmacotherapeutics in this area. So what this research has taught us is that early and aggressive antidepressant treatment increases the chance for a full remission. The first 6 to 8 weeks of therapy constitute the acute phase. And then after that, so the primary goal in that first 6 to 8 weeks is to get a response to drug therapy and improve symptoms. And after that, we want to keep going, and usually patients will stay on this and then work with their therapist on whether or not they need to come off it or stay on it. It all depends on the patient and the situation and what's the underlying cause of some of their problems, their affective disorders. Now, anxiety and depression commonly occur together and tend to reinforce each other. And because there's a crossover in their symptoms and how we can control those symptoms between antidepressant and anti-anxiety drugs. In that first 6 weeks of therapy, if somebody does not have a response to an antidepressant therapy, which means within the first 6 weeks, they don't, with adequate doses, they're not responding, then we need to put them on change their drug to a different drug, or maybe add a second agent in there that maybe has an anti-anxiety piece to it. Of course, our biggest fear with not responding is that somebody will fall out of society with massive depression, will not be able to function at work, wouldn't be able to function within a family or a relationship, and can actually, you've seen what it can lead to with homelessness, desperation, sometimes even suicide. So let's come down to our meds. We're going past the tricyclics, and we're going to come down into our good drugs down here, our SSRIs. Let's see what we're talking about here. They're still talking about tricyclics. So here's some drug interactions that I'm seeing on this table right here. It's 16-6, and let's come down to the second generation. Right here is where our drugs lie, and we are looking at SSRIs and SNRIs, what we usually call them. And in here we see our SSRIs should be, let's see, I don't see them in here. Oh, these are the drugs that, I'm sorry, let's go to the top of the table. So the drugs that interact with our SSRIs are fluoxetine, for instance, so right here would be fluoxetine, are all of these different types of drugs. Now, how often have you had to learn about these drugs this semester? You probably don't even recognize any of them until you come down here to warfarin and phenytoin. Those two you need to remember. The rest here you won't see very often, but you will see warfarin and phenytoin. Phenytoin for seizures, and then the warfarin, of course, is your anticoagulant. We need to make sure that somebody who's on those drugs understands the potential now is that the warfarin or the phenytoin can become toxic, which I want you to think about how these drugs work and what that toxicity would mean. Now, with the duloxetine, with our SSNRIs, if somebody takes an SSRI, like fluoxetine, with the duloxetine, it will have additive effects, and they're then at risk for something called serotonin syndrome. NSAIDs can cause a risk for bleeding, and warfarin can do the same thing. Alcohol can cause liver damage, liver toxicity. So one of the things with duloxetine is that it is metabolized through the liver, and it has an increased risk for hepatotoxicity, which is why giving it with NSAIDs and alcohol is not a good idea. So somebody on duloxetine for depression needs to turn towards acetaminophen for their pain control, and not towards ibuprofen or Advil or some of the others, and needs to be warned about excessive alcohol intake and to avoid that so that they don't damage their liver with that. This area is still talking about the tricyclics, so I'm trying to get down here to our second generation drugs for our mood stabilizing. So our selective mood stabilizing and antidepressant drugs that we are looking at here is our bupropion, and it's a mood stabilizer. A pharmacologic class is miscellaneous, and again, PO. It's given PO. Now look, this one can be given twice a day in divided doses or once a day. And why? Because it's a suspended or sustained release. So really that's the one of choice. And I will tell you that's the one that's usually used for smoking cessation. So we have this drug, Wellbutrin, or also bupropion, that is used in depression because it's a selected mood stabilizing drug. But really our other drugs seem to work a little bit better, our SSNRIs and our SSRIs in that. But this is something that has been found with bupropion to be very effective, is that it works in smoking cessation. It's known as Zyban. That's how it's marketed, with smoking cessation. And when it's used for that purpose, it's in a sustained release and given once a day in a 200 to 400 milligram dosing. When it's used for depression, they take it twice a day, which of course has implications for adherence and missing doses, which is not good when you're trying to treat affective disorders. Our duloxetine is one of our drugs also. It's the SSNRI, and it is given daily, which makes it very good for adherence, or divided. Okay, so now you're probably asking yourself, well, why would you even bother with a divided dose if you can give it once a day? Some of the side effects and the adverse effects that can occur with duloxetine and fluoxetine, for instance, are not well tolerated. There's nausea, there's drowsiness that can occur, and say somebody is 40 milligrams works well for them, or 60 milligrams, but when the first few hours of the day that they have a real issue with the side effects, if we take that dose, 60 milligrams, and divide it in half and do 30 in the morning and 30 12 hours later, then they have a much better side effect profile. They don't get the nausea and the drowsiness as much as they do if we just give it once a day. And the same thing happens with our fluoxetine. As we go up to higher doses, that's going to make the side effects worse. And so then we start looking at having it in divided doses. Let's see, there's a little thing here on monoamine oxidase inhibitors. We're going to skip that. And we'll come down to symptoms of serotonin syndrome. Oh, let's go right here. Okay, so what are some of the adverse effects of our second generation antidepressants? Well, they have advantages over our tricyclics and our MOAIs because they have very much improved adverse effect profiles. So remember how there's that first generation and second generation? Well, the first generation was somewhat effective, but their side effect profiles were terrible. So in the second generation, that's become much better. And however, even with that, look at this right here. Up to 2/3 of patients may still discontinue therapy because of adverse effects. So that is something that we need to work with. And that's why I was mentioning sometimes if we put it in a divided dose, then it's much better tolerated. Some of the most common adverse effects with our second generation antidepressants are insomnia, weight gain. People do not like to gain weight, and sexual dysfunction, a dulling of the libido and a dulling of sexual functioning, especially related to inability to achieve orgasm. This is tied to quality of life. This is very important for a lot of people, and if they are no longer able to have this part of their life that's important, they will stop taking their meds. Just like with our beta blockers and any other drugs that can cause erectile dysfunction, people will stop taking them. So we need to be honest and forthright and tell our patients to please talk to us if this becomes an issue. I'm going to tell them it doesn't happen to everybody, but if it does, talk to us so that we can maybe change to a different drug, a different treatment strategy to see if we can overcome that. Plus, there are other things we can do and talk to them about that maybe can help to overcome that inability. Now, those are just some adverse effects that are pretty well handled, but the hazardous one, the one we really worry about, is something called serotonin syndrome. Right here. We'll put it in blue. Symptoms of serotonin syndrome. Let me just tell you the common ones. And so start thinking, is this something you want to have? Is this something you want to encounter in your patients? Delirium, that's not good. Agitation, tachycardia. This is almost like a panic attack with psychosis, paranoia, muscle spasms, sweating, hyperreflexia. That sounds like, metabolic imbalance, shivering, but sweating also, coarse tremors, and then sometimes what also happens is on the sole of the foot, there's when you do extensor plantar muscle, the sole of the foot has a response. There's a way to test for that. And in the more severe cases, so if this continues to go on, they can actually develop hyperthermia, seizures, the breakdown of muscle rhabdomyolysis, which can lead to renal failure and cardiac dysrhythmias, and then eventually disseminated intravascular coagulation, also known as DIC. So, what is going on with this? Well, fortunately, serotonin syndrome is usually self-limiting, and if we stop the drug, then it will stop the syndrome. And once we stop the drug, the syndrome stops. We don't have to do anything else. And so you have to teach patients that if they're starting to have delirium, signs of delirium, increased agitation, they feel like their heart is beating too fast, they need to call their provider or actually go see someone right away. Because what we need to do is stop their drug, and we need to work with them to see if we need to taper it back up, if they have to just never take a SSRI again, or what. The other thing that SSRIs are associated with is a discontinuation syndrome or withdrawal syndrome. And so we have played with the balance of neurotransmitters and chemicals in the brain when we do this. And if they are stopped abruptly, there's an abrupt imbalance. And it's called discontinuation or withdrawal syndrome. And it's very uncomfortable. and it causes some horrible feelings. Um, this is some of them right here. Flu-like feeling, difficulty concentrating, fainting, lightheadedness, dizziness, GI symptoms, very, very strange feelings, slow responses, dulled responses. And so what we have to do is taper these drugs off very slowly. Now, some of the SSRIs have very short or have shorter half-lives than others. And those are our citalopram, escitalopram, sertraline, and paroxetine. And those are the ones most commonly associated with discontinuation syndrome. You might notice that none of those are the ones we're talking about, like fluoxetine and dualoxetine. Well, that's the reason I'm telling you about fluoxetine and dualoxetine, is because those are the drugs of choice because they don't have as much of this syndrome. And so we use those first and hope that those will work well for patients. So if they forget, I mean, this can happen with forgetting one dose. They can begin to have the discontinuation syndrome. So sometimes, even with a slow reduction in dose, patients will decide to go back on their SSRIs because the withdrawal symptoms are so uncomfortable. And once you start the drug back up, the symptoms go away. It can occur with SSNRIs as well as SSRIs, and our SSNRI is our dualoxetine. So what kind of interactions can happen? Well, let's first understand that our second generation antidepressants are highly bound to albumin. So if you give those with other drugs that are highly bound to albumin, like warfarin and phenytoin, they're going to compete for binding sites on the surface of the albumin. That's why there's interactions between these drugs. And so what happens is, if with a warfarin or phenytoin or can't get enough of the sites, then there's free unbound drug, and then we have a more pronounced drug effect. So in order to prevent potentially fatal pharmacodynamic interactions that can occur, sometimes a washout period is recommended between these two classes of medications. So the patient will go off one and make sure it's completely washed out of the body, up to 5 weeks. I mean, that's how significant this can be before they start on another one. We looked at some of the doses in a table for those, and really your takeaway on the doses isn't the actual milligrams, but that they are dosed, they're PO, and that some of them can be put in twice-a-day dosing to help minimize side effects. Here's bupropion. That's one of our prototype drugs that we need to know about. It's a unique antidepressant. And what makes it unique, you ask me? Well, its structure and its mechanism of action are unique. It has very weak effects on the serotonin activity in the brain and almost no effect on monoamine oxidase, which we haven't talked about because we weren't covering MAOIs. You'll get that in Psych Mental Health. So its strongest therapeutic activity is primarily on dopaminergic and noradrenergic activity. And that's where it differs from our SSRIs and SSNRIs. Originally, it was indicated for depression, but now it's also indicated as a smoking cessation aid. So let's not forget our Zyban. Sometimes for the people who have sexual adverse effects when they're on SSRIs, they will add bupropion to their therapy, and it actually can help to improve those problems that they're having. The exact mechanism in treating nicotine dependence is unknown, but there is some belief that it's related to the way that the drug modulates dopamine and norepinephrine levels in the brain. And so we know those neurotransmitters play an important role in maintaining nicotine addiction. So when you add in something that helps to modulate those, and so if they're still feeling like they get those neurotransmitters, they won't hopefully need to have a cigarette to get the same effect. Bupropion is contraindicated in patients who have a known drug allergy. I'm not even going to highlight that because I know you know that. Anyone with a seizure disorder, because bupropion can lower the seizure threshold. Again, we are talking about neurotransmitters and nerves and the synaptic process in the brain. That is why this is a problem, because we've lowered the seizure threshold. So we want to make sure we do not use bupropion in patients that have a history of or a known active seizure disorder. So our adverse effects here with bupropion are going to be dizziness, confusion, tachycardia, tremor, and dry mouth. I'm not sure if I said agitation, but those are the things you'll see that are problems for patients. And so they may have to come down on doses. If the dose they're on has too much of an adverse effect, they can come down a little bit. You saw there's a range of doses that we have to play with. Some of the drugs that interact are those antifungals, the azole antifungals. Metronidazole is one of those. And drugs metabolized by the cytochrome P450 enzyme system. Let's see, let's look here at the onset of action. I want you to look, I wish I had a red highlighter right now. The onset of action for bupropion is up to 4 weeks. People are not going to get better overnight. They need to be under treatment and therapy so that somebody is monitoring the depression and their response to drugs, because it's not going to feel better right away. It can take up to 4 weeks. Peak plasma concentration happens in 3 hours. Elimination half-life is about 10 to 14 hours. But look at the duration of action. The duration of action can take weeks to months. So it may take a while for it to start working, but then when it does start working, it keeps working for quite a while, like that diesel engine. That's how diesel engines kind of work. Here's our dualoxetine, also known as Cymbalta, often used for fibromyalgia. It is a serotonin norepinephrine reuptake inhibitor, so it's an SSNRI right here. And it is used for depression and generalized anxiety. It's also used for pain resulting from diabetic peripheral neuropathy or fibromyalgia. See, look, I'm brilliant. Did I know that or did I know that? We do know that if someone's allergic, we're not going to give it. If someone's on MAOIs, we're not going to give it. And if somebody has uncontrolled angle closure glaucoma, we will not want to give Cymbalta. Now, here are the adverse effects that might prompt someone to want to take it in the split doses, more than, instead of once a day, taking it twice a day. I'm getting a little crazy with my highlighter here, sorry. Dizziness, drowsiness, headache, GI upset. There's a lot of nausea that goes with this drug. Anorexia and hepatotoxicity. So by giving it in divided doses, it can help minimize some of those adverse effects experienced by the person taking it. I highlighted hepatotoxicity in blue because that is something specific to dualoxetine. It's very important. This is why we need to talk to our patients about the use of too much acetaminophen and too much alcohol, which could have impact on their liver functioning. And they need to have some labs drawn, at least annually to assess their functioning of their liver. It's only available for oral use. And luckily, I mean, at least it's oral, because people will be taking it as outpatients. And then the other drug here is not one that we're covering. So let's look at the onset of action. It's not really any quicker than the bupropion. It takes about 2 to 6 weeks for anyone to start to feel any action from that drug. Takes a while to get your peak plasma concentration up to 6 hours. Half-life is 12 hours. Duration of action is not known. And then here's our other friend, fluoxetine, also known as Prozac. And this was the first SSRI marketed for the treatment of depression, and it is the prototypical SSRI. It was initially indicated for depression. However, that indication from the FDA for fluoxetine has also been expanded to include these other things: bulimia, obsessive compulsive disorder, panic disorder, and premenstrual dysphoric disorder. We do not give fluoxetine to people who are allergic to it or who are also on an MAOI. And the adverse effects are very, very, very similar to the ones we just talked about with dualoxetine, with anxiety, dizziness, drowsiness, and insomnia, which if they are unbearable, the patient can just decide to take the drug in split doses, and that helps to minimize some of those side effects. Again, onset of action is going to be about 1 to 4 weeks. That's probably the fastest one to get it to work, because it can actually work in as little as 1 week, depending on the individual who's taking it and their disease process. We see the elimination half-life isn't hours, it's 1 to 3 days. And then note here that the active metabolite has a half-life of 7 to 10 days. That is why we may have to have a period of 2 to 5 weeks in between finishing one drug and starting another, which if they come, if there's they're taken at the same time, we can have very poor outcomes for our patient. And as we come down, that is the extent of the drugs we're going to cover for pharmacology in this area. You will be learning more about these other drugs as you start to take care of patients who are on them. These were selected, the prototypes that we discussed today were really selected because the high likelihood that you will encounter them in settings that are not just psych mental health, but also in med-surg and maybe even labor and delivery, healthy women, community. So that is why we chose those drugs for you to learn in this semester. I'm scrolling down to take us to this place where we don't forget about the nursing process. Do take a look at this area. Take a look at what it talks about giving specifically some of the drugs. Some of them it won't apply at all because we're not covering them. But just always remember that they are here. Look at this. Look alike, sound alike. And this was the one that I accidentally highlighted at the very beginning, was bupropion and buspirone. They are not the same, and they are used very differently. And this bupropion is our drug, but I had mistakenly highlighted buspirone, and I recognized it like as soon as I did it. I was like, wait, that is not the drug we're working on. They both work on the central nervous system, but they have very different uses. And we've already covered bupropion, and it's used to relieve depression, and it's even given for nicotine withdrawal to help people quit smoking. The buspirone hydrochloride, or Buspar, is an anxiolytic drug for short-term treatment of anxiety. So if you give bupropion to somebody as a treatment for anxiety, it isn't going to help. And by the same token, if you give the Buspar for smoking withdrawal, that's not going to help. So it's very important that we get those things right. Here is the section about antidepressants. And remember, we're focusing on the second gen of antidepressants. And so there will be a area in here about that. Here's some herbal therapies and dietary supplements that might interact with some of the drugs that we've talked about. Here's our second gen antidepressants. That's where our focus is, and the drugs that we've selected to look at. So cover that in your nursing area here, and then come down and look at implementation and how you're going to give these. Again, there's an area here with your second generation drugs. And I think that's pretty much the end of our, I'm looking just to make sure here. That's the end of this Kaltura. I hope it helped and that you have a little bit better understanding of these drugs and how we use them. You will get to actually apply knowledge of psych mental health and depression in your future courses and learn more about some of the other drugs used in this arena. Thank you for listening.